Okay, so good evening, everyone, and welcome to the special webinar we are conducting in collaboration with the Scleral Lens Education Society. So, just to give you all a brief introduction of the Scleral Lens Education Society, it was born from the discussions among its founding members, to share the scleral lens knowledge and introduce more practitioners to the field of scleral lenses. So in 2009, the SLS was granted, non-profit status, and the mission was established to provide the training on scleral lenses to the practitioners. So the SLS has grown to nearly 7,000 members and about 275 fellows worldwide. And we are honored to have Dr. Patricia Flores. She is the international chair of Scleral Lens Education Society, and she'll be taking us through how to master scleral lens fittings and, right from the clinical protocols to fellowships. So let me introduce her quickly. So Dr. Patricia is from Santiago, Chile, and she currently works in a global professional services for the specialty lens division at Menicon. She has an extensive background in vision science, having earned a diploma, a master's degree, and a PhD, all in optics, optometry, and vision at the University of Madrid, Spain. Dr. Flores currently also runs her own specialty lens clinic in Chile, specializing in myopia control, complex contact lens fits for the diseases of the ocular surface. And she is also a fellow of the Scleral Lens Education Society, member of International Association of Contact Lens Educators, and member of the Latin American Academy of Orthokeratology and Myopia Control. She's a board member for Global Ophthalmic Women, which is GLOW, and she is an accomplished researcher and educator, having lectured extensively in Latin America and around the world. So, without wasting more time, I would like to hand over the session to you, Dr. Patricia. Welcome to the session. Yes.
Thank you very much to all of you to participate in this session. I am really, first of all, I want to say apologize for yesterday. I have a complex situation and not was possible to participate in the session. However, today I am totally ready and connect and excited to be here with you because the India ECPs, they have a lot of knowledge regarding to contact lenses. And there exist some institutions, institution more related about the American continent and less than another continent. So my objective or my main goal, like International Chair Scleral Society, is try to diffusion what mean this institution and how that institution can help us to improve our clinical practice, especially in patients with irregular cornea and ocular surface disease. So I titled this introduction lecture about mastering scleral lens fitting from clinical protocols, then some update about the Scleral Lens Society and Scleral Aid War for the expertise, for the ECP who have some expertise in scleral lenses. And at the end, I want to invite you to participate like a fellowship. So we have three objectives here. So first of all, I will mention at the end of this lecture, we have a website where it's a public education. So we have different kind of material and videos, webinar, blog, and also information for our ECP. Yes? Everything is good? You can hear me well?
Yes, perfect, yeah.
Yeah, perfect. So this will be the learning objective. First, explain about the protocol, analyze what kind of update there exist in scleral contact lenses with evidence-based protocols in 2024, how we can evaluate a patient with scleral contact lenses, and what kind of implementation do we need in our clinic practical. So scleral contact lenses, for the ECP who don't have any experience about that, is a type of contact lenses with three different zones. It depends about what kind of branding do we have. we recognize three different zones. The first of all, an optic zone near to the cornea is the base curve and minimal influence overall to the field. That means we expect this part of the optic zone can cover all the totality or all the irregular totality, and then we can go to transition zone. This is the area number 2. The transition zone is between the corneal and scleral. And finally, where the contact lens rests is the landing zone. It depends about you use a mini scleral contact lenses or full scleral contact lenses where the diameter of the landing zone is different, you can recognize these 3 different zones. This is a universal language. How to work the scleral contact lenses? First, we have a corneal clearance. That means the separation between the contact lenses and the cornea. Is understanding we never touch the contact lenses with the cornea. And this is one of the mainly goals to use scleral contact lenses, especially in patients where we get some excessive protrusion, like an advanced keratoconus. Then we recognize the second area, the limbal clearance, the transition zone between the cornea and also between the scleral. This limbal clearance is a little more complex compare what are we thought in the past. Why? Because now the manufactured scleral contact lenses are changes the way they're manufactured scleral contact lenses in the limbal area. And the reason is because there exists many patients, and maybe in your population in India, you will see there exists an limbal zone not symmetrical, very oval limbal. That means if we have a patient with irregularity or ocular surface disease and oval limbal, that means the company, the industry need to change the rules and try to start to manufacture scleral contact lenses with an oval limbal. There also exist the scleral contact lenses, the scleral landing, sorry. The scleral landing is the part where we have the weight of the contact lenses. So at the end of the fit, our fitting depends about the cornea, the sagittal height of the eye, and also depend about the patient. So our success in scleral contact lenses depend about the contact lenses, the fit, that means the cornea, the sagittal of the eye, the scleral contact lenses, the diameter, but also depends about what kind of patient we have in front of us. Is a patient with irregular cornea, maybe only keratoconus, the most frequent condition in our clinical practice, or is a patient with ocular surface disease. The way we treat this patient with the same kind of contact lenses is different. There exists a different traditional scleral candidate. First of all, patient with keratoconus. However, we include patients with post-refractive surgery, ptosis, patients who need to increase the aperture papillary, and also if we have a many and good result with regular corneas, why we not thinking about to regular corneas? So we have different kind of situation here. There is this 3 line. If we can remove that, my darling moderador, I appreciate.
Yes, yeah, I'm trying that. 1 second.
Someone want to draw in my lecture, perfect. So that means I catch your attention. So first, I mentioned to all of you about what means scleral contact lenses, what kind of target patient we expect to have with the scleral contact lenses. Then I explain you about the different areas, optic zone, limbal area, and landing, where the contact lens is touched. Finally, in the scleral, on conjunctiva, Maybe most correct to say conjunctival lenses more than scleral contact lenses, because the reality is these contact lenses, where they are touched is in conjunctiva. So let me help you. Do you need help, my friend, to try to remove that?
Yes, because I'm trying. They are not okay.
Perfect. Now it's ready.
Great.
Thank you. So
I'll just please participants keep your annotations off because it's very disturbing to the speaker. So please keep your annotations off and microphone off, please. Yeah, thank you.
yeah, okay, don't worry. If you have any question, please let me know at the end, or when the moderator Harshnak think about is good, you let me know any question do you have. So the first objective, I am very structured about the objective of this lecture is try to explain why the Scleral Society can help you in your clinical practice with different kind of material. And we abort this issue at the end of this lecture. The second one, explain what's mean scleral contact lenses, the different area, and what kind of patient or target candidate we can use scleral contact lenses. The next topic explain about the basic protocol. We have the branding number 1, the branding number 2, the branding number 3, different country, different of knowledge, different advantage. However, the way to fit or the order or protocol to fit scleral contact lenses is always the same. First, you need to take attention about the horizontal visible iris diameter. And not only the horizontal visible iris diameter, also the vertical and oblique. Because, for instance, in South America, we have in South America very large oblique iris diameter. So we need to be very sure about the diameter we suggest in our scleral contact lens fit is sufficient enough to cover homogeneously at least 1.5 millimeter beyond the limbal in each quadrant. I have 2 skis. I go to the snob and my papa give me a gift. And he gave me a very large ski to play in the snob. However, my mama, she gave me a very pretty and sexy and a small ski. If I go to the snob and I compare about how they deep in the snob with the papa ski large or with a small ski gave for my mom, you have to thinking about, and that is the reason why we all the time suggest to use large diameter or large ski like my papa, because the weight, my weight, 64 kilos, is distributor more homogeneous in 360 degrees in my scleral contact lens fit. That means if I distributor more homogeneous my weight, the ski be more superficial and not go and make an blanching or excessive pressure in the snob. In the opposite way, if I am using a small diameter of ski, that can cause more suction, and also the ski can be dramatically go and dip, and with a lot of force causes blanching and hyperemia. So it's inadequate and causes discomfort. So we want to use an optimal diameter. the optimal diameter not only depends about the horizontal visible diameter of a patient, also depends about the vertical and oblique. And at least we need 1.5 millimeter beyond the limbal in each quadrant. Let me know if you have any question about that. There exists two different kind of diameter, mini and large. Mini, that means is near to the limbal, never touch, and full scleral contact lenses, the diameter have a sufficient, at least 2.5 diameter of the landing zone. Here is maybe only 1.5 millimeters. So this is the papa ski, and this is the mama ski. Here I can distribute or better the weight in 360 degrees and expect less blanching in my feet. Indication for large diameter, any condition where we need to restoration of the ocular surface, sick eyes like a limbal stem cell deficiency, exposed keratitis, ocular surface disease, dry eye, moderate several corneal irregularity, and post-surgery, and for sure, keratoglobus patients. If we use a large diameter scleral contact lenses, we need to know about what kind of problem we expect. Take attention, because I mentioned previously about large diameter, at least 1.5, 2.0, 2.0 millimeter beyond the limbal is the optimal. However, if we go to large diameter, that means we are cover more toric sclera, because the human scleral, how we will see in the next slide, is not spherical, is toric, and is more toric if we go more far away from the limbal to the extreme part of the eye. And also, if we use a large diameter, is more difficult to handling. Some patients drop out to use scleral contact lenses not because they didn't have a good vision, no, because they didn't have good comfort. The main reason, or one of the main reasons why we have dropped out in our patient is because they have really problem to handling these big size. So we have to aware with that. When we use small scleral contact lenses, when we have a mild corneal irregularity, not always we need a big diameter. Maybe in regular corneas, when the corneal is not too much astigmatics, and the scleral is not too much astigmatics. In that situation, we can use in a patient with myopia, with presbyopia, spherical refractive errors, or lower quantity of astigmatism, we can use a small scleral contact lenses. The patient who is happy to use a corneal design, however, for sports with the paddle or football, soccer, they prefer to use a more protective design like an scleral contact lenses. Patient with regular cornea, however, very allergic patients. In this kind of patients, allergic is a very difficult condition. We need to know about, we are not only see patients with irregular cornea, and also our only objective is try to get a good vision with them. In patient with keratoconus, there exists another objective, is try to not make worse condition the allergy, or not to advance the dry eye. not advance or make worse the ocular surface disease. In patients who need contact lenses, the small scleral contact lenses can be a good decision to reduce the friction between the lid and the cornea. If I reduce the friction, I help to reduce the increased osmolarity, decrease the osmolarity, decrease the edema, inflammations, factors. So which factor we need to consider to determine the diameter? First, HBADI, not only the horizontal, also, in my opinion, vertical and oblique, the L health, the type of cornea, regularity, in patient with post-graft, if we have enough quantity of endothelial cells or not, because we can cause edema. Another potential problem may be handling, and also the risk and benefits to use this kind of treatment. When we decide about the optimal diameter, we can go to the second step for any kind of commercial branding. Central clearance assessment. Here we have a corneal stroma. Here we have the thickness of scleral contact lenses. In the majority, but not the totally, the majority of the branding of scleral contact lenses, the thickness is around 250, 350 microns. If you want to know about which thickness it is, you need to call your manufacturer. So here is 350 microns. The branding is not relevant. And then you have the stroma corneal here. The red light means about the quantity of saline solution there exists between the cornea and the contact lenses. This distance represents about the tear film behind the lenses. How we can do that? With a slim lamp, with a yellow filter, with blue light. And also you can use white light, like in this image, white light. You can use optic section, very small aperture, totally intensity of the light, and you can make a cross section. So an increment the high magnification. With these three different steps, you can get this kind of image. Ideal corneal clearance, there exists an lower and excessive. But the answer, or maybe the question we have to make ourselves, is when we measure the clearance. When I go to my clinic and have an appointment with my patient for the fit of scleral contact lenses, when I introduce the contact lenses at the first moment, maybe the clearance it's around 400 microns. However, in that moment, is not the last moment to define if my corneal clearance is correct or not. We need to expand the lens setting, and that means at least 2 hours, 4 hours will be the ideal. With 4 hours, you give enough time to setting the contact lens to the conjunctiva, and in that moment is the correct moment to decide which is your finally quantity of the corneal clearance. So the question is more than to speak about the low, medium, or excessive. Your question is when you measure the corneal clearance. There exists a different kind of tools. One of them is the Ferris State University. This kind of document is free access. So here, from my left to my right, you can see how look an insufficient clearance, 50 microns. In the middle, 300 microns. At the right, 600 microns. That means the optimal is 300 microns? The answer is yes. However, we have to be careful with that. Because you remember in the first part of my lecture, when I mentioned to you about the success or the way we have this standard protocol in scleral contact lenses, not only depends about the lens design, not only depends about the visual acuity we will get or comfort, also depends about the type of patient. With patient with only, and it's easy to say, however, with only irregular cornea with keratoconus, we can have and expect after 4 hours an optimal corneal clearance between 200 microns. However, in a patient with severe dry eye, maybe 200 microns is not enough. Maybe we need 400 microns. And that means it's a problem in our feet? No. There exists some controversy about the quantity of clearance or central clearance in English, corneal central clearance. If it's high, that means I induce an hypoxia in my patient. It's not clear about that. The clearer is if I have some features like a lower endothelium cells, I have to be careful about the oxygen transmissibility. That means the thickness of the contact lenses try to be reduced. The clearance or corneal clearance need to be optimal and not excessive. Be careful about that. As I mentioned previously, the lens setting is super, super important. So we have to keep in mind about if we choose a small scleral contact lenses, I will expect more lens setting over the time, with the time. If I have a large diameter, also I expect the lens setting and reduce the corneal central clearance, but less. So keep in mind about that. Here, recommend about evaluate the central clearance after 30 minutes. For me, it's not enough. In my personal experience, I prefer to wait at least 2-4 hours. In the majority of my patients, I wait 4 hours. How many patients I fitted scleral contact lenses? I don't know. Less than 1,000. And I am still be very careful about that. So the central evaluation over the time, maybe and initially looks very nice, maybe a little prisma here, a little concentration of the contact lenses, but however, everything is covered with tear film behind the contact lenses. However, after a couple of minutes or an hours after, the setting is less. The clearance or corneal clearance is less, and the contact lenses is touch. This is not acceptable. We can maintain this kind of condition because that worsens the irregularity or the progression, increase the progression of the keratoconus, etc., and etc., scarring, hyperemia, etc., etc. So there is another view of the optic section, how we can evaluate with white light, fluorescent, blue light, a small aperture about the thickness of the lenses, about the corneal thickness here, and the thickness of the central, the corneal clearance. We need to focus our attention globally from the right to the left in the corneal area. However, the most important part where we need to take attention to evaluate the finally corneal clearance, it is in the highest point of the cornea. the apex of the cornea, the protrusion of the cornea in that area. Patricia, where I can get that information? In our corneal topography, the elevation map. You remember that? When we use the elevation map, we can get enough information about where is or where exists the highest point of the cornea. In that area, you have to be enough precautions to check about if the corneal clearance is enough or not after 4 hours. Ideal fitting of scleral contact lenses, we need to determine the ideal fit, prevent any effect of hypoxia. If not, we need to increase the decay of our scleral contact lenses. However, at the moment, all the manufacturer, Contamac, Boston, include very, very, very good quantity of decay value, so it's not a problem at all. The lens thickness, try to be reduced as much we can, however, not be insufficient to cause any lens flexion. Be careful with that. And also reduce the clearance how much you can't, but depends about the condition of the patient. As I mentioned, the hypoxia still be a controversy at that moment. People who mention about in patient with endothelium cells problems, we have to be very careful about that. Try to fit and be aware the decay, how much we can't, very high levels, try to reduce the clearance. However, it's not totally clear about if we have a excessive clearance, that means more hypoxia. However, it's as asseveration about in patients with problems with endothelial cells for problems with the coefficient of variation, hexagonality, polymegatismo, pleomorphismo, or something, another endothelial problems, we have to follow up very frequent these patients. And also increase as much we can the oxygen transmissibility. If we have some problems related about the endothelium cells, we can rejections of the transplant or postgraft, complication in vision or physiologic problems, hypoxia long-term. So if we want to some data about when I have to be alert or aware to maybe not fit scleral contact lenses when we have less than 800 cells. That can be a good data to try to keep in mind if you have your next patient, a patient with postgraft, maybe check with your ophthalmologist about the quantity of endothelial cell there exists first before fit any scleral contact lenses. The contribution of tear exchange is very, very limited after setting the contact lenses. That means we have to maintain the oxygen transmissibility how much we can with the decay of the lenses, the corneal clearance, reduce the suctions. When appear the physiological edema problems? After 1 hour. That means I put my contact lenses in my patient and she take a walk out of my clinical practice. They come back 1 hour later, I can start to see some problems. A little dilatation of the vessels, or maybe I can see some microcystis edema, but very incipient clinical signs. That means we have to be very careful about that. Step 3, about the limbal. The optimal is reduce the quantity of reduce the limbal clearance in that area, but never have to touch. when we evaluate the limbal area after 4 hours or after 2 hours. So we don't have the final decision about the limbal clearance immediately we insertion the contact lenses. That is a big mistake. We need to take the decision after the lens setting. If you have the lucky, if you have the lucky to have an OCT, also you can evaluate about how look that clearance. Insufficient is very bad because we can cause touch or pressure in the stem cells. However, excessive limbal clearance is also a problem because can cause more suctions, lens oxygen transmissibility, prolapse. So we want to optimal. If we saw some staining after we remove the contact lenses, that means compression in the limbal area. If we create a limbal section and we see a very limited, insufficient limbal clearance, we need to increase. How to do that? Some branding can only modify the limbal area and try to increase. Also, you can steep the base curve. If you can flat the steep zone, if you can flat the base curve, if you flat the base curve, you can give more chance to increase the clearance in the limbal. I hope you can see my arms. So some brandings only can modify the limbal clearance to try to increase. Other branding used to flat the base curve to try to increase the space in the limbal area or increase the total diameter. That is another option where we can use to increase the separation between the contact lens and the limbal area in my patient. So here it's a little excessive in this part. However, in the transition, it's good. Transition between scleral, the basals still be there, it's not blanching, and there exists the green part in the cornea. Okay? This is a limited clearance. This is an optimal. This is a little excessive. And finally, the last step, or before the last step, because the last step is over refraction, and maybe the last is about the comfort, but the final step is about evaluate the age, the landing zone. This part in the conjunctiva is what make feel comfortable or not the fit to my patient. I need an ideal alignment. That means the basals go across the edge of the contact lenses, not change the direction, not exceed hyperemia, not exceed blanching, similar, different to this picture. However, I don't want to be excessive flat in the landing because that causes discomfort because the edge is touch the inferior lids. Remember or remind about the anatomy of the scleral. If I go to large diameter, I expect more toricity. And that means it's imperative to use branding with toric periphery in the trial set. Be careful about that. In addition to that, we need to know about how is the transition between the cornea, the limbal, and the scleral. And how is the transition about the limbal and the scleral? It's not totally convex, it's more tangential. And also, it's more toricity I am mentioned if I go to large diameter, like explained in this photograph from Randy Kojima and Pat Caroline, the father of scleral contact lenses. So we expect generally rest, not pitchment, no blanching, that improve the comfort, the patient can use for more long time or wearing time very successful during the day. Some wetting of the conjunctiva tell us about this is too much setting in the scleral or conjunctiva in that area. However, we have to check about 360 degrees. Some of the company have flat and steep meridian. Another company include a specific quadrant. So wherever do you decide, you need some design, versatile design to change the landing area. However, you need help from the manufacturer. So your manufacturer is not only in charge to sell the contact lenses, also they must to give you sufficient support. Be careful about that. We don't want compression. As you can see here, there is a little compression in this part. If you have the lucky to have an OCT and profilometry, that will be amazing because you have all the information about the corneal, the limbal, and also how look the scleral, if there is a pinguecula or not, how deep is the smart channel we need in that specific quadrant. If you don't have that kind of devices, it's not the end of the world, because you can use another kind of technology. Your slim lamp, you remove the contact lenses, and you can check about how look if there is a staining in the corneal, in the limbal, or in scleral. So your slim lamp, your microscopy, your evaluation with fluorescein and staining is also your profilometry. Step number 6, the over-refraction. We can get some from toric if it's necessary. Residual astigmatism only after check if not exists any flexion of the contact lenses. How you can do that? You have the patient with scleral contact lenses and you have some residual astigmatism. So you can get and make an keratometry or corneal topography over the contact lenses. If not flexion appear, that means the astigmatism over the contact lenses in the keratometry or corneal topography be 0. But if there exists some astigmatism over the scleral contact lenses, that means there exists a flexion, okay? You need to be patient with your patient to try to explain about the insertion, and that's think about you need more shared time with them. Patient. You need to explain about what kind of solution they need to use. Saline solution without any preservant. You need a daily cleaner and also deep cleaner, enzymatic treatment, more than in the patient where they have an ocular surface disease. The success of the scleral lens fit is not only related about what kind of design. It's not only about if I have a specific quadrant or not. Also, it's about the handling. Also, it's about the complaints. And if you are using or not the care system well or not. Monitoring, control, what do we have to evaluate? History, comfort, how many hours they are using per day, the vision. With the lens, evaluate about if there exists a breeze or not. Then remove the contact lenses and check about if there exists any staining. After they remove the contact lenses, they review your lens care regimen and they schedule the next appointment. Wow, in this couple of minutes, we mentioned about what means scleral contact lenses, the target, the standard protocol. So let's review very quickly about the update for some advanced expert. So The current state of scleral lens practice, they are not only used in patients with keratoconus, they start to be very, very success in a patient with dry eye and another ocular surface disease. We have to keep in mind about the corneal asymmetry exists, but also exists the oval landing zones. Why? Because every day we discover we have more people with oval limbal area. So we can get a corneal asymmetry, oval limbal area, and also asymmetry in scleral. So we have to be careful about that. We have different kind of advanced fitting technology. The first is our slim lamp and our learning curve. That is the most important technology, our learning curve. I not have a very good success in my scleral fit, so I try again and check about the clinical sign. Also, you can use a profilometry, and that can help, it's a reality. Topography guide design, wavefront also can help, or intelligent artificial now start to be some very involved in try to get a better fit. A problem or more useful or more frequent problem, some problem about the visual evaluation. So maybe we need to resolve about residual astigmatism or debris, or maybe a check about the quality of vision. Some market or branding use aberration control. Second, we need to evaluate about the comfort. We can use some scale to see if it's a good, optimal, or very bad comfort, the timing or how long they are wearing, time tolerance, and try to check about how is the landing of the lenses. And also we need to check about the physiology of the corneal, limbal, and scleral after we remove the contact lenses. It's not a problem get some complications, but we have to understand before arrive your patient in your clinical practice for the follow-up, what kind of typical problem we expect. Middle fogging, around the 30% of our patients, they mention about they have problem because they experiment bad vision after 2 hours insert the contact lenses. How we can resolve? Change the fit, or change the landing zones, or change the tear film behind the contact lenses. Conjunctival prolapse, around the 40%, 30% of the patient mention about this problem. Hypoxia, because change about the vision, or the patient feel more suction after remove the contact lenses. So the important thing is not have a problem, is how we resolve. We applicate scleral contact lenses not only for patients with irregular cornea and ocular surface disease, also post-surgery, also keratoprothesis, also pediatric. So be careful with that and be aware about that. Use contact lenses is a very success treatment. In the vision, very success treatment in the comfort, and because not make worse the condition of that patient for irregular cornea or for ocular surface disease. However, we need a very strict follow-up protocols. Initial fitting 1 day, your first control 1 week. Then when the contact lens is setting, the patient use every day at least 1 week, 2 weeks, 3 weeks. The handling is good. They return to control and check the vision, how look the lens, remove the contact lens, see the staining, take some questionnaire about how he feel, and then 6 months, and then after 1 year. Future direction, some company are very innovative to try to increase the decay, improve about how they can reduce the protein deposit, includes different kind of coating, telemedicine. However, this is something we can explain in the future. So I don't want to accept I have a limited time because I have 1 hour provide for your organization. However, I don't want to finish this lecture to try to explain first about how we can be loved a fellow Scleral Lens Society. So first, why we can be near to Scleral Lens Society? Because it's an international non-profit organization, promotes education, research, and clinical excellence. We have expert clinician research in scleral contact lenses. We provide webinar, and also because if you are a fellow, you are recognized like a clinical with significant experience. For that reason, I invite you to be near to this institution. Main requirement, you can complete 10 clinic cases, have 2-letter recommendation from some of the fellows. I am fellow also. I am very happy to help to you. You can demonstrate about active participation in the continuing educations and complete the official application in the website. So with 10 different clinic cases, I am sure you see many patients in your clinic about keratoconus, post-surgery, ocular surface disease. You can get the clinical history. In the website, there is some example about how you can present that clinic cases. So it is easy to follow and instructions, and also explain about the objective measurement, the reason why you decide to use that kind of design, and review about and discussion. You need to document that will be reviewed for the commitment and then give you the approve about you will be a follow. Why applicate international recognition, global networking, exclusive material free for the fellowship, webinars, blogs, material for your patient, opportunity to be a speaker like a fellow Scleral Lens Society. So at the end, I want to invite to you, all of you, to participate and see our website, explain about how to be a fellow, what kind of material do we have, and for sure, if you have any question, please let me know. So that is something I want to share with you. I hope my English is not my mother language, so I apologize for that. We have 100, more than 100 attendees, and that is amazing. I am so happy. So yeah, I am here if you have any question, comment, and I hope you understand the way I explained that, and I am here for you.
Yes, thank you so much, Patricia. We've got few questions. Okay, what precaution should we take with the low endothelial cell? I think you've answered that in the webinar itself. Okay, there's one question from the Rahul. What are the contributing factors to encourage to the scleral contact lens?
Can you repeat maybe?
Yeah, what are the contributing factors to encourage to the scleral contact? I mean, Rahul, could you please unmute and ask the question, or you can.
What kind of factor you mentioned about the physiological, economical?
Yeah.
Rahul, I hope the English is not so bad.
Oh, no, not at all, not at all.
Rahul, are you there or not? Which factor encourage the scleral contact lenses? First, you need to, if I want to interpret your question, you need to know about you need a learning curve. This is the most important factor from my point of view, because there is one study from Ruth Araujo, a very good friend of mine, who is an expert in research in contact lenses, and Eve van der Borf, and they make a study explain about how many feet I need to be an expert in scleral contact lenses. And you need at least 60 feet, optimal feet scleral contact lenses to be an expert. However, you still need a learning curve. Scleral contact lenses can provide more comfort initially compared to a corneal design. However, in a long term, it's more difficult because it's a big contact lenses. and you will expect complication in the short time, medium time, and long time. So you need patience, you need time, you need learning curve.
Yes, thank you for that. Okay, we have another question. Okay, for those who are already wearing other type of the contact lenses, how to, encourage them or convert them with the scleral contact lenses?
Change to change to modality, right?
Yes.
Depends. I have patient, the ideal patient is who is happy with the vision, but is not totally happy with the comfort. This is very easy to try to convince them about why we don't have to try for scleral contact lenses. Personally, in my clinical experience, and just with my staff, if it's not broken, you don't have to resolve. That's mean. It's not existing problem, you don't have to change your fit. It's a corneal design maintain, it's a hybrid design maintain. If you can experiment about risk of dropout because the comfort is not good, the vision is not stable, this patient start to be presbyopic, and they don't want to use glasses, or patient with high astigmatism and regular cornea, scleral contact lenses, or ptosis, scleral contact lenses is amazing option. However, some patients with a high myopia are age around 50, older than us. Hopefully I can say that at the moment. And they are very happy with a corneal design because the cornea start to be a little hypoesthetic. They don't feel the corneal lenses. And they use very easy way the handling. They don't want to change to scleral contact lens.
Yeah, right.
So,
Very true.
we have to be realistic, From my point of view, it's amazing the technology. It's amazing the different branding. It's amazing. It's amazing. I am really, really, really happy about that because we have many, many questions, many, many options. However, we need to know not only about the design, we need to know about the design, about how versatile it is, the warranty. How many contact lenses I have free after fit my scleral contact lenses? Ding, 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 ding. Also, what kind of patient? Is a patient with dry eye? Is a patient with irregular cornea? That patient have money or not?
Yeah, most important thing.
And he can handling good or not?
Yes.
He live alone, is an old person, he can use scleral contact lenses.
Yeah. Very
Okay,
true.
sorry for that
Okay.
long answer.
Okay, now the chat box is flooding with all questions and comments. Okay, let me. Okay, Nagma is asking what are the benefits of the scleral contact lenses?
The benefits, vision comfort, mainly.
Okay, we'll take quickly. Okay, Mr. Manish is saying, hello, Dr. Flores. Thank you for the insightful session. It was truly valuable. And he has a question that in cases where the scleral lens fit appears ideal, but conjunctival injection is observed post lens removal. So how should this be managed?
You remove the contact lenses after 4 hours. You can check 3 hours, but you need that learning curve first. If you saw some conjunctival injection, that's mean you need to evaluate the landing the edge in the 4th quadrant first. And second, sometimes I look in my clinical practice, I didn't see any staining. However, I remove the contact lenses, I see injection. There is some inflammatory factors. and we need to check with the ophthalmology to check if there exists an ocular surface disease more than the irregularity.
Right. Okay, we'll take the next. Okay, any tips on insertion of scleral lenses which we can explain to the patients apart from the routine ones? Monil is
Patient.
asking.
Practice and invite your patient. I will tell you one secret. When I have to teach about the scleral contact lenses, and a man, I ask, your wife is here? I say, yes, she's out. Please come here with your wife, because usually the men are more, yes, ready, but no methodic. So the wife is a very good element. Second one, and no joke, I have a video recording in my clinic. So when I provide my how can I say in English? I don't know. I keep my contact lenses solution, Lucky Prior, the saline solution, and the suction holder.
Okay, yeah.
Also, I include here a QR code. I include here a QR code with a video about me, explain about how to use the handling of scleral contact lenses.
Okay.
Okay, what else?
Yes, okay. Okay, which type of contact lenses are better option for long-term comfort and stable vision? Rose-K lenses or the scleral contact lenses?
Both. Is a optimal fit, both.
Okay. Okay, Akshita is asking, is it okay to take small nap with the lenses? Patient
No,
asked this question.
no, totally no.
Okay.
That was easy.
Okay, patient with mild to moderate keratoconus, do you recommend RGP or scleral lenses? Moderate to mild, yeah.
Moderate. I prefer more tear exchange, always. I prefer a corneal design, if not a scleral contact lens design.
Okay. Okay, how long hours that we can suggest them? Okay, what would be the ideal wearing hours for these scleral contact lenses?
The literature tells us about around 14 hours can be enough. However, it's very difficult to tell one patient about you only have 14 hours to see the world.
Okay.
And that is the reality. So how many long hours? That is a very, very delicate question.
Yeah.
Only need to try to maintain the optimal fit, the design, no staining, no suction, good vision, good comfort. And also use a lot of eye drops without preservant all day.
Right.
And maybe rest in the weekend. In the weekend, not use the contact lenses and use glasses. The vision not will be the same. However, you are rest. You are take a break about the scleral contact lenses.
Yes. Okay. What all special considerations needs to be considered as an scleral lens practitioner while fitting in and ordering a scleral in a patient with a ptosis? Okay, so
It's about if the patient have a regular cornea, maybe try to see the less diameter of scleral contact lenses to try to have the same aperture. So take a vision about the aperture in the other eye and the other eye. That happen, that means you need to increase the diameter.
Okay, great. Okay, Priyanka is asking if patient is diagnosed with Fuchs endothelial dystrophy with dry eye, is she an ideal patient for scleral contact lenses or not?
Absolutely. Yes.
Okay. And what about the MGD patients? Meibomian gland dysfunction.
Yeah,
No?
yeah, absolutely. Yeah,
Oh,
for sure. Less friction. Less friction is better.
right.
And also previous the feet cleaner.
No. Okay, Mr. Manish is asking how many hours per day would you recommend? Okay, we've done that. Okay, OST patients mainly having problem in removal of the lenses. Lens gets, stuck due to the dryness. So how to handle these kind of cases?
Oh, in patient with dry eye, we expect that kind of problem. So there is some tips to try to help them. First, to check about the fit is correctly. This is the optimal fit it is. And second, I use an eye drop and I put in my refrigerator. So
Okay.
when the patient remove the contact lenses, take from the refrigerator, boom,
All
and
right. Okay.
they call me.
Okay, so next one is, okay, sometimes even after a proper landing zone, midday fogging can be seen. So how do you manage that?
About the landing area, if there exists some flat meridian or not. And sometimes it's not about the meridian, it's more than about you need some different kind of solution, more viscous solution behind the contact lenses and cornea. So can be the landing area or can be the tear field behind the lenses.
Okay. Okay, next one is, do you think haptic fenestrations could help reduce the midday fogging? And
You
he
can
would
do that,
appreciate
but
any
you have to be
recommendations.
careful about that. You need to check about where you have defenestrations. Maybe the last resources, personally, I use ACD's defenestration to try to reduce the suction. Because sometimes we use fenestration and we try to resolve the mid-fogging, however, cause very frequent bubbles, So we need to check about when we need, where I need to put the fenestration, and which is the advantage and disadvantage.
Okay. Okay, and Gautami is saying, thank you for the great lecture, Dr. Patricia. So how do you manage inferior decentration of the lens?
Decentration. So first can be the landing area in one meridian, especially in the vertical meridian, is too flat. How you can do that? Make a push-up in the contact lenses. If over the contact lenses, you need to put fluorescein and make a push-up in the vertical meridian and check if there exists a bubble or not, entrance bubble or not. You can check with optic section. You can check when you remove the contact lenses and you can see some staining in near to the cornea and very lower position in the inferior quadrant, that means decentration. How I resolve the decentration? Change the landing zone in one of the meridians. Second, change the diameter, increase the diameter.
Okay, okay. Okay, Akshata is asking, can they play sports football with these lenses and swimming with goggles? Is it recommended?
Swimming, no.
Okay.
And
What about
football, yes.
football?
The
Okay.
swimming is difficult because all the time there is some sport we can use some glasses over the eyes. However, all the time and introduce some kind of water, and that water is contaminated. So if you make that sport to swimming, immediately you finish, you need to remove the contact lenses and clean with peroxide.
Okay. All right, that's it. Okay, we are done with all the questions and comments. Okay, so thank you so much, Dr. Patricia, and I'm sorry for all the annotations. I think most of the people have joined from the phone, so by mistake sometimes it happens. So I apologize on behalf of them, and thank you all for joining the session. And especially to our distinguished speaker, thank you for sharing your expertise, insights, and real world experiences. Your clear explanations. It inspired most of the practitioners who have attended today. We've got almost 120 participants today for this webinar. And thank you all the participants for your enthusiastic engagement and all the thoughtful questions. Thank you so much. We hope this session has enriched your understanding of scleral lenses fitting and sparked ideas for your continued growth in specialty contact lens practice. So thank you all. Thank you, Dr. Patricia, and have a great weekend ahead. Thank you.
Lovely day. Ciao, ciao.
Bye-bye.